all the faculties that come down and took a question. Oh, was there? Did I miss something? Oh, sorry.
And we thought we treated the cardiothoracic surgeon badly.
I'll be quick, I promise.
So Stefan, that was a cool case. I was going to say though, Stingray is not out of the question, so we're actually publishing the failed star with Stingray back in. So that's your next trick if you want. Yeah, credit goes to Dave again. No, in that case, not me, but I get to put my name on it too. So yeah, okay. So I was going to say another zebra in the room. Actually, so we have an electrophysiologist. So welcome to your work here. Is that correct? And specialize in complex ablation device implantation. We're going to talk about ICD placement and SCAD.
Yes.
Thank you.
Thank you very
Oh,
much.
and I forgot to say your name is Matt Bennett.
Yes.
Yeah.
Thanks, guys. I know it's getting late, and we're almost on time for or ready to do the panel. I will be quick, I promise. These are my disclosures. So I'm a cardiac electrophysiologist. So I'm an electrician. I compliment my plumbers in the room. And I put in what are called defibrillators. So defibrillators are like pacemakers that then will restore normal rhythm in the event that someone has a very fast heart rate. This is what it looks like in the, okay. This is what it looks like, and it sits usually in the top of the chest on the left. In most instances, there's a wire that goes into the bottom chamber, the ventricle, and then a wire that goes sometimes into the atrium, which is in the top chambers. Okay, here we go. This person has a very fast heart rhythm. This could be a life-threatening heart rhythm, and often it is. And it's then detected by the device and then shocked by the device to go back into normal rhythm. What this looks like on a chest x-ray is like this. So the defibrillator sits here. This is one of the leads that shocks the person. This person has other leads. The astute observers in the audience can see there's a mitral valve ring, and this is a TAVI, and here's the previous sternal wires. So this gets a little technical, but it's not that technical. And for someone who will benefit from a defibrillator or an ICD, they have to be at risk of dying from a life-threatening arrhythmia that would be effectively treated by the ICD. Sort of makes sense. It should work. They should have something that will work to treat. They should be at low risk from dying of a non-arrhythmia cause. Makes sense. If they have cancer, they're going to die of their cancer, and not the ICD, or then not the ventricular arrhythmia, and the ICD won't help that person. ICDs or defibrillators don't save everybody. There are people who have SCAD, for example, and have refractory arrhythmia that an ICD won't help them. They'll get a shock from it, they'll go right back into the arrhythmia, or the defibrillator won't actually get them out of the arrhythmia in the first place. And then statistically and in studies, there has to be enough time to see the curves separate if you're comparing somebody with a defibrillator and not a defibrillator. Just to remind you what our current Canadian guidelines are. And so primary prevention means someone hasn't dropped dead already. Okay? If somebody's dropped dead already from a ventricular arrhythmia, they're at high risk. Usually defibrillators indicated in those people, and I'm going to come back to that. So primary prevention is somebody who hasn't dropped dead already. And usually what we do is put them on medical therapy for 3 months after they've got a low pump function, or they have to have 3 months of medical therapy. At 3 months after, my colleagues have revascularized them, and 40 days after they've had a heart attack or myocardial infarction. Now, if you haven't done that, then you go back and you do that, and then you revisit their pump function, which is their ejection fraction, and if their ejection fraction is low, indicating they've got a lot of scar, and scar leads to short circuiting, and they're at high risk of arrhythmia because of that short circuiting, then a defibrillator is indicated. If their pump function is a little bit better, then we talk about it, we assess the risks and benefits, and then decide for the patient. What I really want to look at is, because there's very little data, like a lot of the stuff the studies that we talked about today and the issues that we talked about today, very little data specific to SCAD in these patients for defibrillators. So I would like to talk about that 40 days and whether that should be changed for SCAD. So where did this data come from? There are two studies, and I'll go through this very quickly. Dynamit came out in the New England Journal in 2004, looked at 674 patients. They were between 6 to 40 days post-MI. They had some other abnormal variables, and they were randomized to either defibrillator or no defibrillator. The punchline or the major conclusion was that there was no difference in death with the defibrillator in that group. There was no difference in death with the defibrillator compared to medical therapy. Now, when you drill down on the data, there was an improvement in death from arrhythmia, but a worsening in death from other causes. So that gets back to my first point that people have to be at high risk of arrhythmic death and low risk of non-arrhythmic death for defibrillator to work. This was a similar study. IRIS came out in 2009. Very, very similar results, but I want to draw your attention to that 202 of the patients had non-sustained ventricular arrhythmia, which was quite fast. So they were actually at quite high risk of further arrhythmia, but when there was no difference in death in the defibrillator group versus the medical therapy group. Similar findings were found compared to Dynamit, where ICDs reduced the risk of death because of ventricular arrhythmia, but this was offset by non-arrhythmic deaths. As I said earlier, there's very little data in the SCAD population. There have been 3 abstracts, or 2 abstracts, we've submitted a third, and I'll show you that data today. So this was an abstract from the ACC from this year, Chen et al., looking at 488 patients, they're consecutive patients with SCAD. 4% presented with ventricular arrhythmias. On mean follow-up, 1 patient had died, but it was because of a SCAD recurrence complicated by VT or VF. So is it the SCAD, is it the VT or VF? Would a defibrillator have helped that person? It's not clear. And there was 1 death due to sepsis. It was a very bad infection. 5 patients received an ICD, and none of those patients had had therapy. So I think that the jury's out on that one. There was another study. This is from the SCAD Gulf registry. 131 consecutive patients, of whom 10% had very fast or life-threatening ventricular arrhythmias within the first 24 hours. 8 patients had recurrent VT or VF in hospital. 2 of those patients died in hospital, and then 2 of the 8 died in the following year after being discharged from hospital. And it's not clear from this was just an abstract, it's not clear whether those patients died of ventricular arrhythmias or not. So I'm still not sure from this information whether or not defibrillators should be put into people more, like whether the threshold should be lower in people who have presented with SCAD. Now, we've looked at the data here, and we're still processing some of this information, but almost 1,000 patients, of whom 8% presented with ventricular arrhythmias, or had ventricular arrhythmias within the first 24 hours. They're more likely to be younger, statistically, clinically a little bit younger, not that much. More likely to have ST elevation myocardial infarction, which isn't surprising. Bigger infarcts usually. Their ejection fractions were more likely to be less than 50%, so reduced. And left main dissection was more common. In that group who had the life-threatening ventricular arrhythmias, they were more likely to have recurrent myocardial infarction, go on to have unplanned revascularization, which makes sense, they were sicker, and we were more likely to put a defibrillator in, which is, I don't think is, I think that's more a pattern of practice question or issue rather than necessarily that there was some factors that made us put it in, whether it be a reduced ejection fraction or recurrent ventricular arrhythmias. So, but really what we should look at is the follow-up over the next 4 years. They're at higher risk of major adverse cardiac events. Their mortality was higher, and they were higher at higher risk of recurrent cardiac arrest or ventricular leak. So this raises the possibility, and we'll gather more information from drilling down on each of the particular patients, that maybe our threshold for implanting ICDs in this population should be lower. So in summary, ventricular arrhythmias complicate 10% of SCAD presentations. The increase of ventricular arrhythmia increases the risk of adverse events, but I think further evaluations required to determine whether or not we should implant ICDs more readily, whether the threshold should be different in SCAD patients as opposed to non-SCAD patients. So I'm hoping you're glad that I finished early.